Good evening, everyone. It's a pleasant evening here in Boston. It's about 10 p.m. in the evening. We are very pleased to have many people on this call. We are expecting about 40 people on the call from 5 different countries, 15 different organizations. So we are enthusiastic and happy to have all of you join us today for this talk by Dr. Loubaina Buxamusa. My name is Ram Raju. I'm the founder and executive director of Vision Aid. And I'm joined by many board members of Vision Aid, including our chairman, Mr. Puran Dang, our co-founder and vice president, Revati Ramkrishna, our president, Mr. Syed Ali Rizvi, and several other board members, which we will introduce the other board members towards the end of the call. I would like to now go straight into the talk by Dr. Loubaina. The model you see on the screen in front of you, hopefully, is the Vision Aid model. So Vision Aid has as its mission, enabling, empowering, educating and empowering persons with vision-related disabilities so that they can live with independence and dignity. At the core of many of the programs are the principles of occupational therapy. And we are very pleased to have Dr. Loubaina Buxamusa with us here today. She has almost 4 decades of experience as an occupational therapist, both in the practice as well as in teaching. And today, Dr. Loubaina is going to cover a topic, the best practices in vision rehabilitation from an occupational therapy perspective. So at this point, I'm going to transfer the screen over to Loubaina and then request her to take it from here. So Loubaina, can you please share your screen? Okay, give me one moment. I'm just going to have to unmute Loubaina and okay. Loubaina, I have unmuted you.
All right, that's important. Okay, so can you see my screen?
We can see your screen. And
okay,
we can
perfect.
Hear you loud and clear, yes.
Okay, and the volume's okay?
The volume is fine.
Okay,
the slides
great.
are clear.
Okay, so a big hello and welcome to all of you. For some of you, I know it's really bright and early, so thank you for making the effort to be here. And for some others, on the other side, I know it's late evening, so again, thank you for staying up, and I hope I can keep you up for a little while longer. First of all, I pray that you're all doing well, physically and mentally, during these challenging times. And before I start, at the very onset, a very honest confession from an experienced presenter who is just not as experienced in webinars. So if I fumble a little bit through navigating my slides, please excuse me. As many of you might know, I much prefer personal contact, and I hope we can make this a little more personal for you at the end when I take questions. So I will start by a very brief introduction about myself. I'm a pediatric occupational therapist by profession, and rehabilitation of individuals with any kind of physical, mental, or learning challenges is my passion. My interest in visual impairments stems from a very personal journey with my mother, who had severe vision loss due to macular degeneration in the last 10 years of her life, along with Parkinson's. I learned a lot in my journey with her and have embedded that learning into my work in many different ways. What I will share with you today are some of those lessons I learned, which I've woven into this presentation. As Ram had put up in that earlier model, Vision Aid offers a variety of vision rehab programs. And as he mentioned, the principles and philosophy of occupational therapy are the foundation of these programs. So it's these principles that led us to develop this best practice approach which you will be learning about in the next half hour or so. And this best practices approach has been applied pervasively across all our programs, our computer training programs, the assistive tech trainings, the spoken English program, the life skills program, the optical and low vision devices assessment and training, livelihood and employment assistance, O&M, which is orientation and mobility training, and the low vision assessments that we offer. So I will explain each slide as we go along. As Ram noted in the beginning, please write down any questions that may arise in the chat box, which is, I think, at the bottom of most of your screens. And then at the end of this presentation, we will definitely have some time to go through all your questions. So here starts. I'm going to move over to my next slide and hope it works. Here we go. Okay, so let's start out by first trying to understand the term best practice. There is no standard definition of this term, and each organization basically emphasizes what is most important in the framework they choose for service delivery. So we at Vision Aid have adopted a best practice, adopted and I would say adapted a best practice definition, and here it is. So best practices are service delivery strategies or techniques that appear effective based on available evidence. They are client-centered. They're sensitive to the context of the service delivery setting and are responsive to evolving technology, resources, and/or research. So many of you who are here today work for different organizations, all in some way or the other doing some amazing work with a population that is visually impaired. My hope today is that you take away some of this best practice model, which we have developed at Vision Aid, and adapt it in ways that suit your mission and apply it to your organization. Now, coming from a very strong clinical approach and always focusing on doing, I had to move a few steps away from that way of thinking to develop this model. But by the end of it, I was pleasantly surprised to find that by creating and defining parameters for this model, I actually enhanced my clinical practice by increasing my awareness of what was really important to me. And so I urge you in your practices to do the same. So here we're going to talk a little bit about occupational therapy. What is it? So I'm going to play a short video to give you a really brief introduction to it. All right, then. That was really brief, But essentially what I wanted to share was that occupational therapy is basically based on the belief that occupations may be used for health promotion and wellness, remediation or restoration, health maintenance, disease and injury prevention, and compensation and adaptation. So to understand this philosophy, let's first understand the term occupation. Occupation here refers to the ordinary and familiar things people do every day that fill their time and give their lives meaning. In other words, the word occupation represents activities that individuals need or want to do and that are meaningful to them. The key word here being meaningful. So in simple terms, occupational therapists help people across the lifespan participate in the things they want and need to do through the therapeutic use of everyday activities or occupations. These everyday activities are what I just described, ordinary and extraordinary things that are meaningful to the person. These selected meaningful tasks are then used by themselves to restore, reinforce, and enhance performance. From what I saw from our participant list, many of you here today have a background in optometry. So I want to emphasize that the goals of optometric intervention are similar and revolve around restoring normal visual function to enhance performance in everyday tasks. So when it is clear that there is a relationship between a diagnosed condition and performance, both OTs, occupational therapists, and optometrists use all available treatment options to try to eliminate the interference or to teach the patient how to compensate for the problem. As experts in activity analysis and environmental modifications, the bag of an occupational therapist can be defined as how vision impairment has limited the person's ability to complete specific daily tasks. The occupational therapist, then using a specific set of tools, modifies the task or the environment to minimize or remove these limitations. So you can see that our bags are the same, they just contain a different set of tools. So when you create a best practices model for your organizations, remember that you need to focus first on the bag and the goals, and then adding the tools will be a little easier. Here is a slide of the framework on which we have based our best practices model. At the center, you see the client and their performance patterns and skills. And orbiting around the center are all the occupations that an individual engages in throughout the lifespan. And you can see that this model is embedded in the background of context and environment. So we can sum up this model by simply saying that engagement in occupation to support participation in context is the focus and the targeted end objective of intervention and rehabilitation. So to further simplify the core concepts of our best practices in Vision Rehab model, I have listed them out and will try to give you an example of each as it's related to our programs here at VisionAid. So the first concept that we will address is using occupation as a means and an end. So occupation as means refers to the use of therapeutic occupation as the treatment modality to advance someone towards an occupational outcome. The end of the intervention process occurs with the client's improved engagement in meaningful occupation. So our interventions are basically designed to foster engagement in occupations and in activities to support participation in life. There's a dynamic assessment that continues throughout this intervention process. Let's understand this with an example. I've changed names to protect privacy. Shalini is a young lady with significant visual loss secondary to a traumatic brain injury. Prior to her accident, she was a student whose goal was to become a computer programmer. Life changed drastically for her as her accident created vision loss as well as mobility issues. During the entire process of vision rehabilitation, the activity that was most meaningful to Shalini was engaging with the computer or electronic devices. Using these devices as a means, her rehab team focused on helping her achieve her goal of pursuing programming studies. The bag of tools contained environmental modifications, low vision aids, orientation and mobility training, etc. This process was effective because the rehab team was able to use Shalini's occupation as a means and an end. The second core concept in our best practices model is creating meaningful patterns of engagement across contexts. In vision rehab, we assist individuals to link their ability to perform daily life activities with meaningful patterns of engagement in their desired roles and life situations, whether it's in home, in school, in a workplace, or in the community. Here it is important to understand engagement from a holistic perspective and address all the aspects of performance, physical, cognitive, emotional, and psychosocial when providing interventions. So context is an overarching, underlying, embedded influence on the process of service delivery. Our Vision 8 programs are designed to be holistic and try to engage the individual across multiple contexts. So what do we mean by context? Context exists around and within the person. They influence both the client's performance and the process of delivering services. The external context, example, the physical setting and the social context, this provides resources that support or inhibit the client's performance, such as the presence of a willing caregiver, as well as the delivery of services, for example, time limits placed on the length of intervention in an outpatient hospital setting. Different settings, that is school, hospital, or home, provide different supports and resources for service delivery. Next is the client's internal context, their personal and spiritual context that affects service delivery by influencing personal beliefs, perceptions, and expectations. The cultural context is also very important, and this exists outside of the person, but is internalized by the person. This also sets expectations, beliefs, and customs that can affect how and when services may be delivered. So here again is an example from one of our centers that might help us understand this piece of the model. Parvati is a young 23-year-old woman who comes in with macular degeneration and 80% visual impairment in both eyes, with a prognosis to be fully blind in 2 years due to further degeneration. Her external context comprised of living with very supportive parents and a brother in a small one-bedroom apartment. The family was willing to do anything to help her, but their financial means were very limited. Parvati's internal context was defined by her despondency and fears of losing her complete vision and questions on how could she ever hope to lead an independent, normal life again. Her cultural context included the stigma that she perceived would be directed at her family by society, as she would become a burden on them and unable to look after her parents as they aged. So our evaluation factored in all these contexts as we created a model of service for Parvati and her family, which was her external context. The interventions included O&M training so she could learn to navigate safely, life skills training geared towards her independence, assistive devices to help her use her existing vision optimally, and counseling for Parvati and her family to help them cope and adapt to a progressive condition. The combination of these programs created meaningful engagement across multiple contexts for Parvati and her family. Our third core concept in this model is addressing performance issues holistically. Human activities are basically sorted into categories called areas of occupation. As seen in that orbiting model that I had put up in an earlier slide, these include activities of daily living, which are activities that are oriented towards taking care of one's own body, bathing, dressing, personal hygiene, eating, and functional mobility. Then there are the instrumental activities of daily living, which are activities that are oriented towards interacting with the environment around you. These are often more complex and usually optional, such as care of children, financial management, shopping, preparing meals, using the phone, taking medication, community mobility, home management, etc. And then there's education, work, play, leisure, and social participation, which are some of the other areas of occupation. So it is important to address performance issues in any or all areas that are affecting the person's ability to engage in occupations and in activities. Across every Vision 8 program, the participants will not each get the same set of interventions. It is not a one-size-fits-all approach. This is what makes our work both challenging and interesting. We need to understand what the individual's goals and contexts are and customize the intervention accordingly. To illustrate this further, take the case of Nikita, a housewife who comes to the Vision Aid Resource Center in one of our partner hospitals. Nikita has recently lost her vision and she is married with young children and a husband to take care of. Her need to learn computers will be less important. Her need to learn safe cooking and orientation and mobility will be more important at the present time. So the program needs to be customized to suit this need. So in addition to teaching her and creating adaptations so that she can be independent in her basic ADLs, such as bathing, wearing her sari, walking around her house, we also focused on some of her IADLs, such as combing her daughter's hair, dressing her young children, walking them to the school bus stop, etc. This was the focus of our immediate intervention plan. This is what was most meaningful for Nikita. Here is the fourth point of our model: linking client factors to outcomes. Over here, it's important to remember that performance can be influenced by factors that reside within the client. It is important to be knowledgeable about the variety of physical, cognitive, emotional, and psychosocial client factors that influence development and performance, and how illness, disease, and disability affect these factors. It is important for us to recognize that these client factors, which include values, beliefs, and spirituality, influence the ability of the client to engage in occupations. And that engagement in occupations can also influence client factors. The understanding of this interaction should be applied and used throughout the intervention process. At one of our centers, we have introduced a life skills curriculum as part of a 9-month scholarship training program that we offer. This entire life skills program is based on our best practices model. There is, of course, an important generic structure to the curriculum, but then we conduct a needs evaluation and assessment of each student's current performance. And this is what dictates what specific lessons or skills training we need to focus on. This evaluation is iterated at multiple steps during the course of the training program. Linking each client's individual current performance level to achieving beneficial outcomes has made this life skills curriculum a very successful addition to our residential scholarship program. Next, we will talk about one of my personal favorite concepts, which is assessing the client first, then the disability. The evaluation process is critical and sets the stage for all that follows. Regardless of the kind of evaluation being done, whether it's spoken English, computer skills, functional vision, life skills, etc., etc., the evaluation process should be divided into 2 sub-steps. The first sub-step is the occupational profile. That initial step during which the client's needs, problems, and concerns about their occupations and daily life activity performance are identified, and priorities and values are ascertained. The client's input is central in this process, and the client's priorities guide the choices and decisions made during this process of evaluation. Clients can identify the occupations that give meaning to their lives and select the goals and priorities that are important to them as individuals. Remember, our clients, our patients, however you may refer to them, are individuals first, and second, they're individuals with a disability. So to understand this concept, we will talk a little bit about Vishal, a young man with a visual impairment. Client-first language is critical to fully comprehend this point. Client-first language. So right now, make a shift in how you think of your clients. Vishal is a young man with a visual impairment. Do not refer to him as a visually impaired young man. He comes first, then his disability. So Vishal was a young unemployed adult with low vision who came into our resource center at one of our partner hospitals. Vishal wanted to find a job to become financially independent. This became clear during the intake process where the occupational profile was first established. This occupational profile gave us an understanding of what Vishal's needs and priorities were. The second sub-step of the evaluation process, analysis of occupational performance, focused on more specifically identifying occupational performance issues and evaluating selected factors that supported and hindered performance. So once the occupational profile was established, Vishal went through the low vision assessment process. This was where a thorough evaluation was performed and documented. A series of interventions was then recommended for Vishal based on his visual impairment and his occupational needs. These included low vision device training, computer applications training, mobile device training, O&M training, and spoken English training. Valuing and respecting the client's input helps to foster client involvement and can more efficiently guide our interventions. Information about the occupational profile is collected at the beginning of contact with the client. However, additional information is collected over time throughout the process and reflected in the changes subsequently that we make to the targeted outcomes. And here is the final concept of our best practices model: making the process dynamic and interactive in nature. As you can see from this diagram, the rehab and intervention process does not occur in a sequenced step-by-step fashion. The arrows in this figure that connect the boxes indicate the interactive and non-linear nature of this process. The process, however, does always start with the occupational profile. So that's important to remember. Start the process with the occupational profile. An understanding of the client's concerns, problems, and risks is the cornerstone of the process. The entire process of service delivery begins with a collaborative relationship with the client. The collaborative relationship then continues throughout the process and affects all phases of the process. The factors that influence occupational performance continually interact with one another. Because of their dynamic interaction, these factors are frequently evaluated simultaneously throughout the process as their influence on performance is observed. So in Vishal's case, once he completes the basic computer training, if his instructor at a resource center finds him to be performing well and mastering basic concepts, he will be referred for advanced technical training courses. The team also makes Vishal aware that he's eligible to apply for the Vision Aid Scholarship Program, as well as other advanced programs such as the programming course. So as can be seen in the example, a dynamic interaction is happening between Vishal and the low vision specialist and other rehab staff, such as the O&M trainer, the IT trainer, and the advanced trainers. They're all taking into account Vishal's changing abilities, his background and occupational interests, and designing a program which is meaningful for him and best suits his needs. So to sum up, our best practice model has been created as an offshoot of our mission, which is to enable, educate, and empower persons with vision-related disabilities so that they can live with independence and dignity. Our model emphasizes understanding the client as an occupational human being, for whom access and participation in meaningful and productive activities is central to health and well-being. We strive to use a holistic approach which integrates all the elements dynamically: evaluation, intervention, and outcomes, with the patient being at the center of the collaboration team. And finally, as I said in the beginning of my talk, I urge you to enhance the clinical value you bring to your clients by creating a best practice model for your organization. This framework will help you in keeping your interventions client-centric and help you create a dynamic and flexible model of service delivery, which will take the wonderful work you're all currently doing to the next level. Thank you.
Thank you so much, Loubaina. That was an excellent presentation. And at this point in time, we welcome questions which can be asked in one of two ways. You can either type the question into the chat window, or you can raise your hand. In Zoom, there is an option on the bottom right of your screen usually. You can raise your hand, and then we will unmute anyone who's raising their hand so that you can actually ask your question. So you can either type your question or raise your hand and then ask any question. So I'm seeing a lot of thank yous coming in through the chat window for you, Loubaina.
Thank you.
No questions yet. So I'm going to unmute everyone briefly, and let's see if this works. It's a large group. We currently have 28 people signed into this call, and sometimes noise and background noise can get in the way, but I'm going to take a chance and unmute everyone. But I will request anyone who's not speaking to please mute yourself to cut the background noise. And if anyone has any questions or comments, you're welcome to speak them now. So everyone is unmuted, but if you are not speaking, please place yourself on mute now.
So,
So
there's a question here.
Yes.
From, Ali Rizvi to everyone. If someone has multiple disabilities, then how does one start the assessment process?
Am I muted or I'm unmuted?
We can hear you, Loubaina.
Okay, that's a great question, Alibhai. I would say, and I think it's different in different organizations, but here we really emphasize a team approach to this. And it's really looking, as I mentioned in my talk, it's really looking at the whole person. So going back to that whole, the piece that I talked about, the occupational profile, right? So this is here you have an individual who's got multiple areas of challenge, not just vision. So where do you start? So you start with that very important piece that I talked about, which is the occupational profile. Who is this person? What is it that is important to them? If it's a young person, like a really young child, then obviously the family's intake is extremely important as well. If you're dealing with an older adult, the family intake is still equally important, but the person also has a voice. So really trying to understand what is most important to them. And then going back to looking at every area of disability and working as a team to understand where do we start. It's not just vision. There could be mobility issues, there could be auditory issues, there could be a whole bunch of issues. But I come back to the core of let's look at the person first and come back.
Thank you so much. Any other questions?
Loubaina, this is Aparna. That was an excellent, eloquently put presentation. I have a question from the context of, I know from your work environment at the Shrewsbury schools, and how do you deal with a patient or a child who is in a classroom setting who is visually impaired? Like, how do you address their visual needs?
We get people like you in. We work, in a school-based setting, and if you're talking about a school-based setting in the US, we are definitely limited in terms of what a school-based therapist can do for a child with visual impairments. But, we do call in consultants because we do not have vision therapists as part of school-based staff. And what I have learned in my work with vision therapists is really looking very closely at the environment for these children, because so much of what we take for granted in terms of lighting, in terms of font size, in terms of placement or position of the child in the classroom, the things that we don't think about for children who are not visually impaired comes into play here. So we're very sensitive to that and create what we call in educational terms accommodations for those children in a classroom setting so that they can learn alongside their peers. Did that answer your question, Aparna?
Hi, Loubaina. This is Ali again. One more question for you. Thank you so much. It was a very terrific and very engaging presentation. Very well done. Love the slides and the video embedded in the presentation.
Great.
So this particular model that you have discussed today, is this going to be prevalent in not only the US economy, environment, but also, for example, say around the world in lesser evolved economies around the world?
Absolutely. Because this model that I described and that we put together at Vision 8 for our programs really ties in with the mission of our organization, and it's got nothing to do with, I would say, the cultural context or of financial perspective. It's really what is at the core of our practice. Which is, like I explained, some of the key points are it's holistic, it's client-centered, it's really taking into account what is meaningful for that client, because that is the way to to make it purposeful for the client. So that's a very good question, and I would say that it's pervasive across, this model would work across all cultures, all contexts, from my perspective, yes.
Thank you. Do we have any other questions, any other comments? We have another 10 minutes, so we are open for any comments. If anyone has any experiences they want to share or talk about, since we don't have questions, please feel free to do that.
And you can also type your questions into the chat. I just got onto the chat, so I'm kind of going through it. I see a nice comment here from Shankar Netralai, which is one of our partner organizations. And it sounds like, what you've written in the chat, that you also deal with a lot of children with multiple disabilities. And I have to say that in my experience, and I did some work at Madurai, at Arvind this last summer. And, when I saw children there with visual impairments, I also saw children, most of them had multiple disabilities. So, when you're working with children with visual impairments, you often do get the clinical picture of a child with multiple disabilities. So I you know, it is challenging. It is challenging because, you know, everything is important all at the same time.
Hi, hello.
Yes.
Yeah, Ram, let's try unmuting everyone and see if
Yes.
we can
I
have
already
more of a
did that.
discussion.
Yeah, I already unmuted everyone.
Oh, you did? Okay.
Yeah, but I think a couple of people seem to be having some technical issues. Like Aparna, I think she's unable to unmute herself, which is why. And I am able to. Now I just was able to. Aparna,
No, I can unmute myself now. Just now, as you let Anna Maria also wanted to ask a question and she couldn't unmute. So
Okay.
Yeah. Hi, Loubaina. I'm Anna Maria. I work with Aparna at Boston Children's Hospital. I just wanted to say the occupational therapists actually helped build my practice. They were so helpful in so many ways. I learned so much from you guys. It's amazing. So like one of the practices that when I graduated from optometry school was cardinal Cushing and, you know, New England pediatric care and the May Center. They were all occupational therapists that were so involved and interested in learning about vision and how they can help these kids. So I think it's really important to have a team approach and try to learn from each other. But I'm grateful for a lot of the occupational therapists. I still keep in touch with a lot of them. So thanks again for this lovely presentation. It was great.
And I think that whole team approach piece, because, you know, we all don't know everything there is to know about working with people with, you know, such intense challenges. So the more we can learn and draw from each other and rely on each other's expertise, the better for our child, for our client. So yes, I've learned a lot from the vision specialists that I've worked with. So thank you.
Anyone else have any questions or comments? Aparna, did you want to say something? I'm sorry, you had some trouble unmuting yourself earlier. No, not sure if that issue is recurring.
Anybody else who can, you know, maybe want to type their questions in? Anyone?
Yeah. All right, so I guess we'll just, if nobody has any other questions.
Hi, this is Sabira. I have a question for Loubaina.
Please go ahead.
Loubaina, do you have a different strategy for different age group, like children versus adult?
No, not really. You mean when it comes to, you know, working with vision impairment?
Yes.
Or just
no, visual impairment with, you know, you are dealing with different disabilities with the visual impairment.
Right.
So there is any different priorities or different, you know, strategies to deal with this different age group?
Well, you know, when I talked about the occupational profile for a child, you know, the biggest thing that we focus on, which is, you know, anyone take a guess, what is a child's occupation? Play. Children learn through play, right? So that is their biggest occupation. So when we look at client factors, when it's related to a child, and again, depends on the age of the child. If, you know, if it's an older child, then, you know, of course, the education and learning piece comes in as well. But really focusing a lot on play-based interventions for a child versus for an adult. You know, like when I talked about Vishal's example, you know, you know, you're going to look at his occupational profile and try to determine what is meaningful for him. And he's able to give us feedback, whereas a child is unable to give us feedback. So sometimes we have to rely on some external factors, you know, like family input. And then, of course, keeping into account that, you know, a child's occupation is primarily play. And most of learning in early childhood occurs through play. So would say that would be a little bit of a difference, but at the end of the day, it's really what is important to that individual.
Thank you. Great presentation, Loubaina. Great. I enjoyed it.
I hope everyone stayed awake. I'm just going through the chat to see if I missed anything. I think there's a question here on whether we have handouts. I know Ram was recorded this. I'm not sure how you can view the recording. Yes, and I would agree with Saranaya that, you know, it's a very individualized intervention, evaluation and intervention process.
Yeah, I think everyone should be unmuted now. Can people try now?
Yes, now I think it's unmuted. That's okay now. Yeah.
Yeah. Aparna, were you saying something? Apologies.
No, no worries. It's all covered. It was an excellent presentation and nicely done. Nothing missed from me not saying anything.
A very good presentation.
Oh, that's Dr. Parikshit Gogati. How are you, Dr. Parikshit?
Hi, I have to get back to patient care, but we learned so much, ma'am.
Okay, I'm happy. I hope it was of use to,
Yes,
you know, people who are here from different organizations.
Yes, ma'am.
Yeah. Thank you so much, Loubaina. So on behalf of the whole team and all the participants, big thank you. So if you have any questions, you have the email of Vision Aid, send it to us and we'll forward it on to Loubaina. We will also be circulating a recording of the talk for everyone. So if someone in your team couldn't make it, feel free to share the recording. We'll also post it on the Vision Aid Academy. And just want to remind everyone, the next talk is going to be on Thursday. It's 4 to 5 p.m. and it's by the director of Perkins India. Her name is Kristen Layton, and she will be talking about best practices in interventions for children with multiple disabilities and vision impairment, MDVI. So that's going to be another excellent talk. And we already have 2 other talks coming up next week, and please stay tuned for the details. We will send those out by email to everyone who has registered so far. So just look out for that. And we appreciate having all of you on these calls, and it's great to see so many people from different parts of the world joining in. These are times of social isolation, but we are finding social togetherness here and discussing a wonderful and meaningful topic. So for closing, anyone has anything else to say?
Yeah, I think.
Thank you, Ram and Loubaina. Wonderful talk, and we deeply appreciate it. Thank you.
Thank you so much, Purani.
Yeah. Thank you, Loubaina. It was a great presentation.
Thank you.
Loubaina, it was really, really, I learned so much. Thank you for a very informative talk.
Thank you.